Okay, moving on to part 2, the unstable or critically ill patient. So going back to our main or first slide, we're now moving from this end of the spectrum to this end of the spectrum, where the patient obviously is sick and needs help quickly in order to stabilize them. And this group of patients in most hospitals that I've worked at will go to a resus bay or some or similar, right? And we'll just go through like the mindset of how to think about these patients, because the main thing about these patients is that we need to buy time. We usually not like, it's a spectrum, right? Some of the patients down here you might have time and so on, but some of the patients that are like in extremis, you really don't have time. You have to know what you're going to do before you're going in there. So we'll be talking about some strategies and again logistics of how to manage these patients so that you have a chance to actually fix these. All right, so one of the main model that I'll use going through this part is this model. So we have a sign in, then you have then the patient comes in, you'll get a report, and then you'll go through your O-ABCDE. O is for overview. We'll go through details of this, and then you have two parallel running pathways. To begin with, this is the pathway that we are following, but in parallel, as we gather data, this is a generic pathway, but as we like treat as you go through the ABCDs. If they have low oxygen saturation, then you'll give them oxygen and so on. But as we go along here and by ourselves time, we find out, we get a hypothesis of a syndrome that we can treat more specifically and try to reverse whatever is happening, okay? And then after a while, you will do a sign out. The patient is either stabilized or is too unstable to stay in the emergency room. They might need to crash, or repair, what you call surgery right away, right? Like trauma or like damage control surgery. So they might go just somewhere else to a PCI maybe if they're unstable from a STEMI, so on and so forth, right? Where you don't need any more diagnostics. So again, this theme of knowing what to do and actually getting it done, like the difference between amateur and expert, between strategy and logistics, is a theme that is highly in the center here as well. And a lot of this pertains or is part of this big group of things that I love to talk about, and I've talked about at length in on other lectures, but I haven't done a summary lecture on it. Non-technical skills. These are in the background all the time during this, and we'll go through these. And then this is a central model as well that we'll be going through, which when we are trying to treat the patient and going from generic to syndromatic treatment, we want to see the patient improve, and we want to continuously to update our hypothesis as we're getting more data and treating what we think is the right condition, like treating with syndromatic treatments. And if it's going the wrong way, we need to go back into our hypothesis and see, is it our hypothesis that is wrong, or is the patient just too ill? Okay. Some of the models that we'll be going through, again, here are the pictures that some of the central models in the critically ill patient that we'll be going through that I think are central for you to know. And we'll start with signing in. Okay, so signing in, you get, like in most hospitals, you'll get like some of these patients might be walk-ins. Then when you do the triage, you can see that they are in such a bad way that you need to go to the resus bay right away. That's the minority, I would say, of these. The majority are patients that pre-hospitally have been identified either by trauma criteria or by vital signs or by some other either algorithm or just gestalt from the ambulance service that this patient is in a bad way. And then they'll be calling in a few minutes before they come in to say that this patient is coming in. This is what we know. What do we do in that time? And that's kind of like a relay race, I would say. That's the mindset that we need to have. So that and the sign in that we're doing with our team is the main purpose of it is to get us up to speed, to make sure that we are that we're doing all that we can. And we're like getting up to speed so we don't stand on our feet when the patient rolls in, but we are actually already at the speed of the patient coming in, so we can pick off or we can start off where the ambulance left off. Okay. Okay, so yeah, just to show that this is like a relay race. We need to get up to speed when we are like we can't stand on our feet. We need to get up to speed when we are getting the baton, the patient. And how do we get up to speed? That's what I'm going to talk about now. So it's like a team huddle, right? Emergency medicine is a team sport, and therefore we need to know our team. We need to know both ourselves, but also our team, and we need to be able to work in a team because all things that are going well will be a team effort. It's not just us. It's not just someone else. It's the team, right? So there's one way. I usually like lots of ways to do the sign in. I'll give you an example of a popular one that Cliff Reed have made, mixed in with some of the stuff that some of the other expert teachers in emergency medicine talk about, and also Eric Driver, who's also I would consider one of the expert teachers as well. So there's this 0-point survey, as Cliff Reed will call it, or step up. So STE, which is self, team, equipment, and patient. So self is that you have to think about yourself. Are you ready to take this call? Are you ready to be the leader in the resus bay right now? Have you been to the toilet? Are you too stressed out? Have you been too exhausted? Have you eaten? Have you all of these things? Maybe you might be able to just quickly run to the toilet. Maybe you might quickly be able to, if you just pick the patient from the stable patient, the stable patient group, then you can put them back so that they don't have to wait until you're back again. Or like you can make some preparations like that. The team, that is the team, who do we need, right? First of all, you go around like, who's here? I would say, hi, my name is Peter. I'm the team leader. I'm a specialist in emergency medicine. And usually in our teams, we'll have a nurse and a nurse's assistant. That's usually our basic team. And they will, and then as part of the team, depending on what kind of patient who's coming in, or what kind of pre-hospital alert that we'd heard, like the report, then we might need some kind of special competency. So, for instance, if the patient is called in with an A problem, then I would like to have an anesthesiologist down, or someone who can handle the airway. I might even want, and that's going into the equipment. I might even want the trach kit at the bedside, so that you don't have to pull that in right when we see the patient, but we have that ready already, right? Another common thing is if the patient is ceasing pre-hospitally, then usually they would already have gotten their 2 doses of benzodiazepines. So what we want to do right away when they get in, we want them to have their Keppra or whatever second line drug for status epilepticus that you might use in your shop. So that's what you want to give them and you want to that you maybe don't have to open the bottles, but you might have the bottles standing there, and I need someone in the team who's competent for doing that, because sometimes the competency is not like sometimes we don't have the competence in the team, right? So sometimes there might be, well, if you have someone coming in with COPD, exacerbation in a really bad way, or someone with severe asthma, or someone with pulmonary edema, or just dyspnea. If you have someone who's called in with dyspnea, you really need someone who can do NIV or BiPAP. And if you don't have that on your team, you need that, right? So you need to call that person in or switch that person in, or if that is needed, if you need that competence, you need to have a plan in your team right away. If that happens, then we do this, okay? Then you call that person in, depending on how likely it is to be used. Okay, so that's the STE. That's how I usually. I know pre-hospitally they would think about environment here as well. And that can be like crowd control. Are there too many people in our environment? Sometimes for cardiac arrests in our hospital, or sometimes for in other hospitals. If you have a child coming in, usually there will be 50 people. If it's a prior one resuscitation, there will be 50 people in the room, or 40 at least. So that's the crowd can be too much. And with more crowd, there's more noise, there's more complex decisions, more heads to criticize or not do, or like, so crowd control is part of this. And there's lots of other things that you can go into Cliff Reed's lecture to like go into details of. At some point, you also have to think about the patient, and for the patient walkthrough with the team, I usually use the S-bar. You can use whatever you want actually, but I usually use the S-bar. That's what we teach in the EMCC, right? So this would be the situation. What do we know? Like, so maybe some 30-year-old male ceasing pre-hospitally. Background: we will look at the computer and see if there's any clinical frailty scale, like some of the things that if you don't only have a few minutes, what is important to find out, it depends on what kind of resuscitation is coming in, right? What kind of patient is coming in. For really sick elderly patients, I usually want to know if they have any season what do you call it, like no compressions, like no CPR orders, what their like status is at home. Are they what are their mobility? What is their clinical frailty scale score? Like how likely is it that we can pull this patient out of it without making them suffer unnecessarily? So if it's a neuro patient coming in, I really want to know the last good neuro status or a neuro exam that's been done, because that's what I'm going to compare what I'm seeing with the patient now to. So I'll be comparing the last status to this status, and if like you have what is called recrudescence, sometimes if you have a stroke then or any neural lesion, then with time it'll heal, and when you get an infection, you'll get weaker in that limb that you were weak in before, but not more weak. You are not allowed to be more weak than when you had your stroke. You're allowed to be as weak or a little bit better, and it has to be the same distribution, right? So that's why the neuro exam can be really important here, before and after. You want to know something about blood thinners usually, and like, so you look at the computer and I usually write down what is happening, what I get from the background. Then you have analysis in the S-bar, like what do we think we should be doing as a team, and what could be going on. Some call it like in trauma, some trauma resuscitationists call it the trauma game. What do we think? Well, in trauma it's quite a narrow, usually like it's a D problem or a C problem, sometimes an A-B problem, but usually it's kind of a narrow differential. In general, like medicine and surgery, and like it could be a bit wider. And we need to like, okay, so this patient has a COPD where it might be COPD exacerbation, and they're dyspneic now. It might be pulmonary embolism. It might be, so what do we want to do? Like, we are going to do the ABCDEs, we know that, but what are we going to prioritize? And if you have someone coming in who's bleeding, one of our colleagues in Skåne, he had a really bad trauma coming in, and one of the things that he just said to one team member was like, your only task is to just put in a IV or an IO and just start giving blood. That's the only thing that you need to focus on. So like you can give tasks depending on what the team thinks could be going on here, right? And then from this kind of discussion, sorry, you'll have a plan of what to do the first couple of minutes, right? And this is a preliminary plan. You have to update this. This is the you in the step up. And you realize, like, sometimes you'll do this first and then you'll go through this. That's why I have this arrow here. I usually like toggle between these two. You can do however you want, right? This is something I usually do in my head. This is something I do explicitly in the team. But then I might say, like, okay, I want Kepra drawn up. I want someone who can do an IV. If we think this is what's going on, then I want this and this and this. So that's like that's the battle plan, right? Another main thing about doing the sign-in is also kind of setting the tone that this is a team effort. We need all hands on deck. I need all of your eyes, brains, and ears, right? We need to like do what you call psychological safety, right? If you see something that I'm doing wrong, if I'm missing something, if there's something that you think that might be going on that I'm missing, then please tell me as a team leader. I want to know, right? And we'll talk about the non-technical skills that goes into that later on. If you want to go into details with this, and I think you should, if you haven't already, then the 0-point survey conceptual map on YouTube by Cliff Reed, and he has a study on this as well, where he goes through all of the details of his step, or his way of talking about this. As a team leader in this situation, you'll be flying ahead of the plane, right? So besides thinking about what the patient probably is going to need, then you also think about the logistics of it, right? So okay, this patient will do this and this examination on them, but then pretty quickly what is going to be needed is radiology. So if you are in a big center, then sometimes you will call radiology beforehand to let them know that this patient is coming in. If it's a trauma in a big center, you might call trauma, or they might be down already to see the patient. But just to let them know, like let the next level know that the patient is coming in. I like to, in our hospital, look at if there's any space in the higher level areas, such as EMA or EVA, because that's oftentimes where the patient needs to go. Okay. And there's another thing that we have to think about here as fly ahead of the plane. That is the opportunity cost. And now we're moving a little bit ahead into the treatment, but sometimes like opportunity cost in emergency medicine is a central thing. Like a lot of the examinations that we can do in the emergency room or the resus bay, they're not dangerous. Like it's the data. It might get us some data, like ECG or POCUS or whatever, but they're not harmful in and of themselves. They don't harm the patient, but they might take time from something that would be more important for the patient, like going to the CT. So the only reason why I would put if you have someone who is dyspneic, I want to utilize POCUS in a way so that it changes my way. I know this patient is already going to the CT as a default. So why would I use POCUS? Well, I would use POCUS if I need to treat something right away. That means, can I see a big heart, like big RV, like right ventricle, meaning that it might be a pulmonary embolism, so I have to treat right away. It might be It might be that the lungs are either wet or dry. If they're dry, then I will need the CT probably. If they're wet, then maybe I have the diagnosis already and I won't need the CT because this patient might have pulmonary edema or a lighter version of that, maybe just decompensation. That could be treated in a different way, and we might not need the CT. So that's how we should use the POCUS. But or in the trauma section, like if you have a patient who has a C problem, you want to find out where the C problem is in the trauma. Is it tamponade? Is it bleeding somewhere? So because if it's none of those, like if the patient is stable and you just go to the CT, you don't need to do the POCUS. They'll just take too much time, right? So it's only if the patient has to surpass the CT actually that you'll do the POCUS, or that's the main purpose of it. I'm not saying that there might be, like, from a diagnostic standpoint and from a syndromatic data gathering, there might be some reason to do these things, but we have to think about everything we do when time is of the essence could be harmful to the patient. So we need to think, do I really need to do the POCUS here? Do I really need to do an ECG here? Do I really need to do these things, right? And yeah, that's the important thing of opportunity cost. Okay, besides the sign-in, I would encourage you to think about what kind of group of patients is coming in, because there might be special, like, generic considerations to think about before. So if it's a trauma, you need some kind of heart board, right? You might need on the heart board, or a trauma transfer we call it. On that heart board, you will probably need to have a if it's a big trauma, level 1 trauma, then you'll have to have a trochanter binder or a pelvic binder, right? Lying on there beforehand. You might want IOs ready to drill. You might want to think about increased ICP. So you want the patient maybe tilted in the flat, like the bed is flat, but the head is the entire bed is tilted 30 degrees, and so on and so forth, right? In pediatrics, I would encourage all Swedish doctors to know about the EPET, which is a great homepage that lists all the doses for children, right? So especially if you're a hospital that don't see children like ours, like not officially, but we do have children that come in anyway. You will do a wet flag or have a app on your phone that you know beforehand how to use, because then you can, like, calculate the doses, or at least estimate the doses. They might not always be in complete agreement, but that doesn't matter. You won't do a great mistake if you, like, if there's a couple of milligrams difference between these, like the way what kind of app you use or what kind of mnemonic you use. But so just so you're kind of in the ballpark of what you're going to do. In pregnancy, there's a thing called TOLD, which is tilt, like move the uterus to the left so that there is no vena cava pressure. Give oxygen because they have low tidal, like they have low reserves. So give oxygen early on, even for just minor hypoxemia. Put in lines, but the lines have to be above the diaphragm because of the venous return. It's problematic to do it below the diaphragm. So only in the neck or the arms. And then think about dates. Do you need to call gynecology or obstetrics and to see if the baby has to come out, right? And if it's the cardiac arrest, we'll go into that in halo scenarios. You might have to deliver the baby yourself. Is there a CBNRNE situation? Do we need to decontaminate the patient beforehand? And in severe agitation or malignant hyperthermia and so on, do we need to actively cool the patient and so on? There's lots of these action drills, kind of like scenarios that we can go into. This is part of our mental models that we built, so that we kind of know what kind of mental model this patient happens to fit into, because then we know the treatment right away, what the basic things we need to do right away is, okay? Then we also need to know when you're doing the sign-in, we need to kind of consider, are we doing a serial or parallel thing with this patient, right? Let me explain. So usually when I'm a doctor, or I'm the team leader and the examining doctor usually, and I have my nurse and I have the nurse's assistant. We'll be doing a serial. I'll do the A, then I'll do the B, then I'll do the C, then I'll do the D, and then I'll do the E. That's great for most like light resuscitation patients and to moderately sick resuscitation patients, right? But the problem is if something needs to be done really quick, where the patient is really in a bad way, then I need more hands. I need several things done at once. The archetype thing is example is if this is a big level 1 trauma, then you both need someone who can assess the airway and maybe start the process of preparing intubation whilst someone is putting in drilling in blood, drilling in a IO to get blood, while someone is on the chest trying to do a pleurocentesis or similar because there's a pneumothorax or whatever, right? So so here you need a team of small teams, right? And exactly how this is organized depends on where you work and what kind of scenarios you're going into. But examples of this could be in most hospitals is cardiac arrest, and that's a really hard scenario, right? Because your team assembles as it goes along, and that what is required of the team leader in the parallel teams, even though more things can be done much quicker. There's a high demand of the team leader and the team to be highly skilled in non-technical skills. Right, and we'll go back into what those what those non-technical skills are. But it's amongst other, it's leadership, it's communication, it's followership, it's decision making, it's like lots of things, because lots of noise in these scenarios. If you ever simulated these or been in such a scenario before, so lots of things needs to happen, and that this coordination becomes complex, right? So that these are really good. But you need to be a strong or a clear team leader. And sometimes you can toggle between these two. You might start off here, and you see, oh no, this is a cardiac arrest. Okay, or this turned into a cardiac arrest. Then you go into this mode. So you might have to toggle between these two, and clearly say, okay, and then once the team of micro teams comes in, I'm the team leader. I need this and this and this, or we have a cardiac arrest with a pregnant woman, meaning that we have a micro team. We need micro teams for A and B persons. We need a C person. We need a D person, who's usually also the A person, because the GCS can also usually be done like that. And you need an E person or similar, right? And the details of how to do that depends, and it depends on what kind of condition is going on, right? Another topic related to sign in is when there's no time to sign in, right? It can be called the zero warning resus, that where it's usually these patients who's walking in, who suddenly collapses or becomes much worse, and you're the doctor on the scene has to act right now and assemble a team. If you want help with this kind of discussion, then you can check out, for instance, this amazing podcast, Zero Warning by Scott Weingart, and also this How to Stop Spiraling When Massively Stressed. This one is in part 1 and in part 2, and then in part 2 they also talk about amazing things. So check those out if you want to know more about that. I'll just be talking about a few key points. There's also the emergency mind. Dan Dworkis, sorry for the slide being a bit cut off here, but Dan Dworkis has a great podcast about exactly these kinds of patients, and a book that goes along with it. So he's an emergency physician who's made these amazing podcasts and books about this specific topic. So check out him if you don't haven't already. My recommendation for these is that just as you do build up illness scripts of your of the time critical and likely conditions that you need to know about, you also need to build up a like an action drill or a archive of situations or conditions if they arise. What will you do? What can you do? What's the first thing you have to do so that you can so that you can buy yourself time to organize the team. So, for instance, you can call this if this then that. If this happens, then I'll do this. If you suddenly have a patient who's unconscious plus abnormal or no breathing and no pulses, and there's a fundus at the umbilicus, then what you will do is, well, this is a cardiac arrest. You will start compressions, and if there's a fundus at the umbilicus, meaning that uterus on the umbilicus, then you will have to very quickly think about doing a resuscitative hysterectomy or perimortem section, right? Has to be like, depends on the literature you read, but yeah, as fast as possible. We're talking, so a lot of these situations is what you call a low opportunity or occurrence. Low occurrence doesn't happen as often, and they're high acuity. These are what we call halo scenarios. And I have an entire separate video about halo scenarios, but I guess the most important thing to know is that we, like, if such a condition arises that there's just too little time, like the reversibility of the condition, like a cardiac arrest with a pregnant woman after week 20, if that conditions arise, we have a few minutes to get the baby out, and we might not be able to get the expertise down that we need to do this. So that's where we need, as the emergency physicians, as the best person in the room, has to do the procedure. Even though we're not the expert in it, we have to practice these so-called halo procedures. So if you're interested, I have an entire video on this, so check that out. I will just skip through here. These if this then that doesn't have to only be halo scenarios. It can be like they call it action drills as well in the Stimulus podcast and MCRIT. If you have someone with like difficult access in a critical ill patient, then if you don't get a like 1-2 IO, if you don't get you get 2 tries for an IV. If you don't get that, then you'll get an IO. If the IO doesn't work, then you'll do a crash femoral line. So you kind of know what should you do in these scenarios, even though you don't know what is wrong with the patient, but you do know what to do if this happens, right? If you have someone who is hypotensive, then you will crack the cocard and then you'll give cardiac arrest epi. If you have one is like if you have someone who's bronchospastic and they look like they're really in a bad way, then you will give them adrenaline intramuscularly and draw up intravenous before putting on the mask, because yes, asthmatics and COPDs should be treated with masks, but you won't make it. Like if they're in extremis, then you need to put that drug in right away, right? And so on. So that's kind of the sign in part. We do the sign in to try to get up to speed, get the right competences into the team. If there's no warning at all, like if we get just cold, we just get you need to come now, then you need that's where we need to like get our bearings. Okay, what do I have in front of me? Is it someone who is like, you might be able to state like, I'm the leader. I'll be the team leader if that's okay with everybody. We have a cardiac arrest. You have to state what is it and what is the action plan right now. Now we'll do the ABCs. We'll get the patient up here, and then you'll have to think about what to do, and then you can use your archive of action drills to see what has to be prioritized in the first seconds, right? This will buy you time, hopefully, to think and organize like more like a normal sign-in. Okay. Then we'll go into the O-ABCDE. So once the patient now this is all of this has been kind of before the patient comes in. Of course, with zero warning, then they're already there. But this has been like before the patient comes in. What do we do once the patient is here? Okay. So the O-ABCD, or also from generic to syndromatic treatment of the patient. So the first thing that happens once this wait time is over is that the patient or the ambulance comes into the ambulance bay, and if it's a worrisome call, I will always go into the ambulance bay to see how the patient is looking before they come into the resus bay, right? We have a rule, the ambulance is rolled in right next to our resus rooms, but just those few seconds, I can quickly tell the team, oh, the patient is not looking like she's or he's in extremis. We can be more calm. Sometimes I'm on the fence, or I'm on the borderline of calling anesthesia. Like it's an A problem, but it's a minor A problem. Maybe I want to see the patient first. I have time, and then when I see the patient, then I want, like, once I go out into the ambulance bay, then I see, oh yeah, it's a real A problem. I'll call anesthesia right away. Okay, so I like to just go out and check out how does the patient actually look. But then once the patient comes into our emergency department or the resus bay, then the first thing you have to consider is not like is actually what should we do now? Should we make the ambulance people paramedics, should they do the history, or should we move the patient so that we can get going with the patient and we'll get the history afterwards? That's the first decision. So when do we need to move the patient before the story, and when does the team get the story? Because it's important when we get the story. In most patients, we all ears need to be open. We need to listen and not do anything else. And do we have these maybe 2 minutes that it takes for the ambulance personnel to do an admist or a sign over, or is the patient in such a bad way that we need to just move them right away? I've been in like most of the scenarios. Most of the scenarios will be, yes, you come in, like at least in our hospital, because we're not a level 1 trauma center. We'll get the story from the ambulance, and then we'll move the patient. And a few examples of when I have moved the patients just like because they were in such a bad way. One was a woman in her 50s who was in extremis with bronchospasm. She was alerted in as a COPD exacerbation, but she didn't have a COPD. She had asthma, and she was unconscious. So that was where, like, before the ambulance started talking, I'll just stop, move the patient over, give her adrenaline right away, and then I'll take the story from you afterwards. Another scenario where we will do that would be cardiac arrests. I don't need the entire team to know what the story is from the cardiac arrest. I will get the team going, and then I might, as team leader, afterwards go to the ambulance personnel once the team is going, especially in these parallel teams where several things have to happen at once. Then I'll go talk with the ambulance personnel, get the data, the important data, like in the cardiac arrest, like how long was the downtime, what was the first rhythm. All of these things are important to get, and I usually have a checklist for cardiac arrests to know, like, what information do I need to get, because there's a lot usually. Also in seizures, like how long have they been seizing, what medications have they been given, and so on and so forth, right? And once I've got that report, whilst the team is moving and trying to stabilize the patient, then I'll go back to the team and say, okay, team, we have this scenario now. This is what I heard from the ambulance personnel. We have this, like, the vital signs are this. This is, and you'll do the kind of an S-bar handover to the team, just so that the patient can be stabilized beforehand. Okay. Okay. And how do you know? Well, there's several scenarios as we just talked about. I just gave you some examples, but the examples like are like when do you move the patient and when don't you move the patient before getting the handover? Well, if the patient is LSS equals to 1, this is the LSS score. It has a 0 and a 1. If you're at LLS 1, then you're in a bad way, because LLS means looks like shit. So if the patient looks like shit, and how do you that's kind of a main skill to know, when because sometimes the ambulance personnel, even though they're experienced, they would not know whether the patient is in a bad way, whether they're really sick or not. Right? The COPD, what they thought was COPD was actually asthma. That's one of those. Asthma patients can be tricky, and they do look really bad. Like a COPD person that is unconscious, that is bad, but an asthma patient that is unconscious, that is pre-arrest, right? So there's a difference. And one of my friends, Nicholas Gray, Australian emergency physician and all-around amazing guy, he taught me this. Is the patient sick or looks like shit, or is the patient not doesn't look like shit? And do I know what it is, or don't I know what it is? So if they don't look like shit, but I don't know what it is, that's all right. We will find out through tests. They're stable. We can examine them and so on. If it's looks like shit, but I know what it is, like I knew that was asthma, I might not be happy. I might be a little more stressed, but I know what to do. It's just a matter of I already had the script for this. I already have practiced this in my head. I know what to do for a bad asthmatic patient, right? One of the problems is if I don't know what it is, then it's really what North Americans will call a sphincter tightening resuscitation, because I don't know why this patient is sick, but they look really sick. Then I'll have to call in lots of people, right? If the patient if the patient, I know what it is and is they don't look like shit, well, then I'll just treat that, right? So especially this area is really something that is hard for us, and we need to call in help and to get more hands on deck when we get these scenarios. So I talked about so which patients do we move for that's what we use the O for in the overview, right? So there might be, besides the ones that are unstable, there might be other ones. So one of the patients that we don't want to move beforehand is the CBRNE patients. This is where we want to always have some kind of think about our protection, right? It doesn't have to be CBRNE patients. Always think about our protection, right? So, but if they have specific chemical, then you might toxic contamination. You might need to do some kind of cleaning of them or washing off of them. If they're radioactive or nuclear, then you will need to have what you call Geiger measuring, and there has to be which has to be on the patient or in the vicinity of the patient, so we know how much the personnel is being exposed and so on. If it's explosive, then we have to think trauma and so on and so forth. So CBRNE, you need to take your precautions, and you need to know how to don everything from a light protect PPE to a hazmat suit in these scenarios. And sometimes the patient is really critically ill, but we need also to think about our own safety first. The most common one are infections in most patients, right? So is there a contamination risk? Do we need how much gear do we need? We for those of us who was there during COVID, we know so yeah. All right, and then we talked about if the patient is an extremist, if they look like shit, then also we need the story first. We need to do something before the ambulance give the report, and this is where we what the team needs to do is, okay, it's a cardiac arrest, then we'll do compressions. We have to get that going before we can get the report. If it's an AB problem, if it's what you call an AMAX4 or an asthma, as we talked about, or anaphylaxis, then we'll get. I don't want to wait to get adrenaline like there was 2 or 3 minutes before the report. We need to get that right now. Or if there's an obstructed A, like it's a acutely obstructed A problem, then I will just give it. You just need to intubate this patient now, or something like that. Then you have to do it now. That's rare, but it's you can have those. Then like in trauma, you have like the C, A, B, C, D. I put the O because it's in the overview. There's more than just a C to think about here, but this is like the C of the C, A, B, C, D. Is there blood on the floor or profound shock? Are there open bleedings, right? Then you have to use tourniquets and compression and so on, give blood in, and then you can get the report afterwards. In D, if there's ongoing status, I want the patient moved right away to get them Keppra, and then they can talk. If the patient is malignantly hyperthermic, then I had a patient like this coming in from the marathon. I've had several of these patients coming in from the marathon, but I remember one clearly where the patient was 41 degrees. They hadn't cooled the patient pre-hospitally for some reason or another. Or at least they had done it they had done it, from my view, insufficiently. So the patient was like severely agitated and very hot, and I and it came in with clothes on still. So I just, like, the first thing, remove all clothes, get them in a hot, we need to go get like in our hospital is towels. So we like cold towels, and then do this kind of loop where you go from the sink to and get new towels, and then put on the patient so that they're covered, all of the body mass is covered in towels that are cold, so that they can be cooled down as quickly as possible, which is the most important thing in hyperthermia, which is not like just fever, but hyperthermia where it's like the regulation system is off, and like heat stroke. This was a heat stroke. And then also in the overview, sometimes you have these patients coming in with a lot of police, and maybe they will be in handcuffs, maybe they will have a helmet on, which prevents them from spitting on people. In these patients, you need, before they are moved, you can get the history here, but before they're moved, you need to get, like, you have two choices, either you, or you have several choices, but one of the main choices is this a patient where we think they might be something wrong ABCDE wise, like they have a somatic condition that I need to treat, or that is life-threatening. Then we can, in Scandinavia, or at least in Sweden and Denmark, we can do what is called NERP. Like we can save the patient's lives outside of like any kind of I can give them fluid, I can give them medications to calm them down, all right, so that we can treat them, and I don't need any fancy laws or like psychiatric assessments to do this. I just need to know that they are in a bad way, and this might be life threatening. And for me, when they come into an emergency room and they're severely agitated, and they don't want to get anything, if I believe that they're like, someone has evaluated that they are in such a bad way that they have to come to the emergency department and not just the psychiatric ward, then there are someone who has assessed that these are patients that are in life-threatening condition, that they need to be assessed, and that gives me the green light to just like try to do what I can to save their lives, which means sedating them oftentimes. And sometimes, depending on where you work, you have to use sedation, usually Haldol or similar, in combination with some kind of benzodiazepine, especially if they're hypothermic. That's a really good combination, especially with benzos just, but or olanzapine. But if that doesn't, like, if it's really a severe case, you might need ketamine, like a DSI, kind of scenario, like a delayed sequence intubation, where you kind of calm them down so that you can get oxygen to them with ketamine as the facilitating drug. Or you can give them, in our shop, we often use propofol. We call it our anesthesiology colleagues, and then they give them propofol. But if it's a kind of a dicey situation where it's not too obvious that it's a really, really sick patient, but they are definitely in need of some kind of workup, you might need to do a psychiatric evaluation, and do, in Sweden, what you call an LPT, where you just have to sign, like, where you have to put in the psychiatric order to force them to be treated from a but that only works on a psychiatric condition, and sometimes you need some kind of psychiatric expert to like evaluate whether this is valid or not, and so on and so forth. So that's, yeah. But these are patients that you need to calm the room, and also sometimes in trauma scenarios, you need to calm the room, right? So before everything can happen, a calm room is really important. So you need this calm room, and in order to get that calm room, you need to treat the patient's pain or treat the patient like, so sometimes you just need to get them some kind of quick painkiller, fentanyl, L-fentanyl, ketamine, to get the room calm, okay? And this comes sometimes with some risk, especially in trauma where there might be occult hypotensive, right? So, so it's an evaluation all the time. But these agitated patients is also part of the overview. Also, for our safety, we might have to call police, or we might have to call guards to help us, right? But now we get into like, so we talked about what's first, the story or moving the patient, and so we talked about these are the three things. If the patient looks like shit, if there's CBRNE, or if it's really agitated, you might want to do something before moving the patient. You might want to get the team going with the thing before waiting those 2 or 3 minutes to hear the story. And once the team is going is doing their thing, then you'll go and take the history from the ambulance personnel yourself. Okay. But then we go into like when the patient is actually in front of us and we actually do have to assess them. I sometimes call this the hardest arrow in the emergency medicine. Like, you have these two parallel tracks, right? You have the generic or data collection part where you treat as you go. You do your ABCDEs. So and your ABCDEs has the purpose of firstly identifying any problems with the patient and treating them accordingly, right? So if they have and generically, like you don't consider what kind of syndrome they have at this point. You might know some bits and pieces of the puzzle, but you will, like, so if you have a patient who comes in and has is hypotensive, you'll get them fluids, right? If it's a trauma scenario, you will get them blood. If they have and you might tilt them in Trendelenburgs. You might if it's a B problem, you'll get them oxygen, and if oxygen is not enough, you'll get them NIV, and so on and so forth, right? So this is just generic without considering what the underlying cause is. I know it's not like perfect. Oftentimes you actually already know some bits of pieces and pieces, but because as time goes on, like it's not only data, it's not only assessing the threats, it's also gathering data for your puzzle. And this puzzle is collected. This is the hardest arrow. It's hard sometimes to like put the puzzle pieces together to build this picture of a syndromatic, what is going on, this syndrome, right? And the syndrome, the syndromatic treatment. Some might ask, like, why do we need to treat syndromatically? Can't we just treat generically all the time? Well, I mean, you can. Like, if the patient has low blood pressure, you can give them fluids, but at some point you need, like, if they're anaphylactic, you will need to give them adrenaline, right? You will need to give them a specific treatment. If you don't give them that specific treatment, then they will die, right? There is this the Buddha's arrows kind of Buddhistic thing that Eric Driver uses as an analogy here. And I see if I can remember it. It's a rider who is shot by an arrow, and he doesn't want the arrow, like it's a poisoned arrow, and the rider who is shot doesn't want to pull it out unless he knows who took the shot, right? And he dies. So and the thing is, like, we don't, the purpose of this analogy is we don't need to know what we're treating. We don't need to know the entire puzzle. We don't need to know who shot us. We don't need to know, is it actual anaphylaxis. We don't need the we just need enough data points to get a kind of gestalt kind of syndrome to see, okay, it's probably this. We'll try to treat with this adrenaline, and especially if the thing that we are treating with is not that dangerous, it's not a irreversible thing, then it's not a problem. Another thing that comes to mind is, okay, we think this is pulmonary edema because the patient, once we've gone through the generic data collection, we see that on the POGUS they have B lines, there's a bit of lactate, and they have a high blood pressure. So yes, B lines on your chest can be fibrosis, and the blood pressure might be borderline 200 or 180 or something like that. But it's worth trying to treat them with nitro because it's a reversible drug that goes out really quickly, and we won't do much harm in a lot of these patients, right? So we might as well try. We can give them NIV for a while and see if that works. So that's why we need this syndromatic kind of treatment. How do we get that arrow? How do we know that? Well, we reflect on our cases. We use deliberate practice. We'll talk about what that is in a moment. We'll do sim training. We'll do case reviews. We do study. We've developed these good mental models for different syndromes. So if you have a dyspneic patient, a B problem, then we'll go into the mental scripts that we might have in the emergency department for B problems, or for A problems, or for C problems, and and then we have our illness scripts as well. We kind of know how these patients could look like, right? So that's how we develop this syndromatic kind of archive or encyclopedia that we are drawing from, and that develops through expertise, and it's hard, right? It's hard as a beginner to know patterns that you don't know, right? That's why you need to do your homework before. You need to do your pattern recognitions. You need to know your action drills, what to do if this and this happens. You need to know what kind of treatments are reversible and which ones are non-reversible, and so on. Yeah. Let's go through some advice on the generic data collection. So generic ABCDE tips, I would say 3 days ago, the purpose of this is buying time and collecting data. Don't worry about the cause at first, unless the patient is an extremist, then you really have to think fast and try to do the action drills things as we talked about in the 0 warning sign-in thing. Yeah. 3 days ago, you do under A, you do basic airway maneuvers like jaw thrust and so on. Might put in a oropharyngeal or nasopharyngeal airway, oxygen, and if that doesn't work, it might be shunting, and then you put on NIV. C, fluids, and then maybe vasopressors if that doesn't work, and blood if it's a trauma. And then it's important to do this. We'll come back to this, but there's this iterative process that you do something and then you will come back to see, did it work, right? And this is because if you do something like that is a data point for our syndromatic treatment, right? So if we do something and we have a hypothesis that this is the problem with the patient has anaphylaxis, we think, and we gave them adrenaline intramuscularly, then it doesn't work. They're still in a bad way, and the blood pressure is worse now, and now they're unconscious. So either what we did was insufficient, like we need to give more, just like IV, which is sensible. But it could also be that we are on the wrong track. Like we're doing something wrong here. It's not anaphylaxis. It's another reason for their shock. And then I'll go back into my mental picture of what is shock, what kind of checklist things do I need to check with a shocky patient, and usually point of care ultrasound is a great help here, right? Some courses will teach you that the O-ABCDE is a religion, like you have to go through A and keep going through A until you fix A. But I disagree with this. I think it's mainly from the ATLS course, and that's a specific, that's a trauma scenario, and maybe in some traumas that would be advisable, or if you have to, ATLS is taught in the entire world, right, to everyone. And of course, then you have to have rules. But I would not be religious about only doing the A, because sometimes there's a there's a B or C reason why there's an A problem, or there might be a D reason, like if you have a stroke or something like that. Of course, you have to manage the A, but sometimes it's not as clear cut as ACLS wants to make you think. And I also think that I want to be opportunistic as well. So yes, the A is probably easy, but I don't want to wait. Like once the patient comes in, everyone tries to like do vital signs on the patient and so on. And if I have to wait on everything all the time, then nothing. There's a lot of wasted time where I just wait around. So I will jump to where I need to be, or jump to what is lacking, and then I'll jump back to, like, I will what I only want from B, for instance, or the only thing I want on the patient is a saturation, right, or a SAT, or a POX, right? Because if I have a POX on the patient, then I know, first of all, I have a saturation. I can read it. I can read the level of the saturation. Second of all, I have a circulation on the patient as well, because if the curve of the POX is good, then the circulation must be good as well, right? So this gives me a lot of information really quickly, and I don't like. There's always like, how much should we put into each letter of the ABC to do a good assessment? It depends. The SWISM and Air Driver would say this: you have the 4, 3, 4, 3, 4. Kind of like 4 things under A, 3 things under B, 4 things under C. It depends whether it's a trauma or it's a child, or it depends, right? So, but there is some kind of generic thing that you have to go through, and I mean, as long as we're gathering the data, I don't prescribe to doing this necessarily in a very strict A to E. The general way to do it is from A to E, but you might skip a letter here or there if you do already have, for instance, your saturation curve. You don't need to do the full B first. You can move to where the money is. I would usually go to POCUS oftentimes if you have a symptomatic patient, because that's where the money is usually. Focusing the lungs, I can see, is it dry lungs or is it wet lungs, right? I'll try to, and then I can always get the lower tier information, like auscultation of the chest. It's only really important in certain scenarios, I would say, and then I can get that. Yes, exactly, and go for where the money is. Vitals are vital. What is more vital as well, like the absolute, like, this is an entire lecture on and of itself, but in children especially, the vitals are very, very vital, and you need, but it's not only the absolute values of the vitals, it's also the trends, right? So the trends of the vitals are often not stressed enough. Is the patient going up or down in blood pressure? Is the patient going up or down in saturation and so on? What were they pre-hospitally? What are they now? Are they a exactly. And maybe you always need to have vitals in context, right? So maybe they have a low blood pressure, okay, but are they otherwise perfusing well? Are they talking to us? Have they urinated? Is the MAP pressure okay? Is the pulse pressure okay? How does their skin feel, and so on and so forth. So when you're in assessment of shock, for instance, you need to you need to think of perfusion. You not only just one vital parameter, right? You need to think about CRT as well, like capillary refill time. If you believe the Andromeda 2 studies, right? So, and it's also important from the vitals, how does the patient look? Like, it's also like with context, right? So how the patient looks is important for maybe not just vitals, but also like the point of care testing. So my classical example is your COPD patient. If you have a patient who has normal PCO2, but they seem like they're really, really dyspneic and bronchospastic, then that's an asthma patient in extremis, right? even though the PCO2 is normal. And on the other hand, you might have a PCO2 that is really, really high, but the patient is looking quite good, and that's because the pH is normal, and that would be your COPD patient oftentimes, because they've compensated, and they're just a little bit decompensated now, but not in the same way as an extreme asthma patient. And as we talked about already, bedside or point of care tests are your friends. I often go for where the money is. You need to know that your auscultation, like what are the limits, and like the likely ratios for this, like in an emergency resus bay are quite poor, right? So you need to use tests that get you to where you want to go as quickly as possible, because time is of the essence, right? Have your own generic approach, as I said, like the Swissum has the 3-4-3-4-3, and you can always add stuff when needed. So, for instance, if you have your patient who has infection and is unconscious or obtunded, then you will check your neck stiffness. You might check in your patient who's a toxicology patient, you will check reflexes, because they might have hyperreflexia or hyporeflexia, as in or increased tone, or clonus, as in serotonergic syndrome, and so on and so forth, right? Yeah, and if you know what it is already, like if you know off the bat, like, and this, like what I talked about, the hard arrow there between generic and syndromatic treatment, as you get more experience, that kind of putting the puzzle pieces together doesn't take too long, or it takes less and less time in many patients, right? You've seen the generic patients before, and then you'll just go and treat, like even before doing the ABCD sometimes. Then you'll go get adrenaline. I've already done the ABCDs by just looking at the patients. Of course, you need to be careful. Like you shouldn't be anchoring either. But these cognitive biases is one of the things that I've not put into this lecture, but I've done many lectures on the cognitive biases before. I mean, and the take home there is it's a balance, right? There's a good thing about like an expert's system one kind of thinking, and good like mental models. If it's low risk, then go for it, right? If you really think that is it, then go for it. You might not have time to think about it later. But if it's a high risk thing, like giving thrombolysis for PE, then you might need to think a little bit more about it. And then you want to gather a little bit more data before doing so. You have these for the generic and more syndromatic things, just like you had your illness scripts for dangerous and likely diagnosis, you also have the procedure scripts, right, and action drills. And like different procedures you need to know as an emergency physician. Some of these, just a segment of these, are halo procedures, right? But the others are also like action drills that you need to be able to do and know like contraindications for, indications for, and so on, right? Moving on to the syndrome management, and we already talked about this. So the patient has different syndromes. I use another analogy with this, and usually I use the starry night sky, and where we see a lot of stars, and some of the stars are brighter than others, and from these bright stars we might see a constellation. You have someone who comes in with stridor, redness of your body, and low blood pressure. What is the syndrome? Most of you will be screaming, "Oh, this could be a different things, right? This is if it's low blood pressure, low perfusion, it's shock, right? But depending on how the redness looks like and how the stridor is this is most like this anaphylaxis could be sepsis with a upper respiratory reason, right? Like an ear, nose, throat sepsis, like epiglottitis could also be, right? Sepsis with epiglottitis. But and could it be pulmonary embolism? Not so much, maybe, right? So anaphylaxis, or maybe less likely sepsis. So you have already here from a few data points, you have your hypothesis number one and hypothesis number two, maybe, right? And what you'll do with the rest of your time here is like you'll try to treat, if the patient is really in a bad way, then you'll just, okay, this might be anaphylaxis, I'll treat it because it's like this patient needs vasopressors, they need adrenaline right away. And then, as we talked about, you might back off and see, okay, this is help. While you're trying to stabilize the patient, you'll by time you'll get more data. You might do an assessment to see, is there a throat infection? Is there like, or if it's going well and it's really clear that it's an anaphylaxis and they're getting better, then then it's, or you'll just observe, see whether they get better, and if they keep getting better, you'll observe them and give them another dose once they need it. Okay. But these are constellations, right? You might suddenly get a new data point, right? Once you go through your systematics, you'll get, oh, they also had fever, then anaphylaxis maybe is less likely. It didn't like cause much harm that we gave them adrenaline, but we probably should be focusing on this now. If there's stridor, yes, then we might have to inhale them with adrenaline, and it might be a septic epiglottitis, this one, right? But always with these critically ill patients, you have to have these mental scripts of like these big syndromes, like shock. What like is the shock? We'll go into those in a little while. But is this shock is like hypovolemic shock? Is it cardiogenic shock? Is this like, and you use your ultrasound and your clinical know-how to figure out whether it is or not. Okay. Let's say you have a suspected PE in a pregnant patient who is week 20 or more than week 20 and in cardiac arrest. So you don't have too much time to do this, like gather data, revise your hypothesis, and adjust management. Like this is the cycle that we do in the syndromatic treatment that I've been talking about. You gather data. Okay, we got the 3 data points that made our constellation of anaphylaxis true. We treat it, and then we treat it with adrenaline, and then we see, like, we have time to gather more data, and then we see from the treatment, did it help or did it not? And either we need to give more or in a different way, or we have it we think it might be something else, and we have to revise our hypothesis and give the treatment for that, right? So that's the iterative hypothesis testing that Sarah Krager has talked about in her lectures on this, and they're really great, so you can check those out. And as we talked about treatment from hypothesis or not, well, should we treat or not? Well, what is the risks? Well, or like if we're not, what is the risk for not treating? I put these on wrong. The risks would be for not treating is like you have no time. You need to treat the patient before they go into cardiac arrest. So that's a benefit, right? But the harms might be that if it's a treatment that's irreversible or might complicate the next kind of treatment. So if in this example, if you have a pregnant patient who needs, you have 2 decisions to make. Like if you're quite sure about your pulmonary embolism differential diagnosis, you need to treat with TPA 50 milligrams, right? Sorry, 50 milligrams of alteplase right away. But if your hypothesis is not correct and you gave the 50 milligrams of alteplase, then the next step would be to, and like the patient is not ROSC in ROSC, then the next thing would be to get out the baby, right? And that's a perimortem C-section. And I'm not sure if TPA and the perimortem C-section will go good together. Hopefully, like, and PE in cardiac arrest is notoriously hard to like diagnose, right? There are some animal studies that say like the blowing up of the right chamber happens to some extent, at least, in pigs, and is probably extrapolated quite well to humans, but yeah, so it is at least a little bit hard. So if you don't see the like ultrasound DVT scan where you see an obvious one, or an obvious clot, then you might have to like try to systematically think through your 4 H's and 4 T's really fast, and see, okay, is there anything else? No. Okay, then it can only be PE, and then you can try to treat. But these are the kind of things that we have to like script in our head and see what would I do in this scenario. And we can test these things on ourselves when we do cases. You can do shadow boxing. MCRIT has great shadow boxing cases. You can do shadow boxing, and you can do it with your own team, right, or your own in your own group, or with a friend who knows emergency medicine. But you can also like you don't have to do this necessarily for all scenarios possible, but so you know, like kind of the ballpark of all the scenarios. Okay. There's this notion of what fails best, right? It's a thing in complexity system thinking, because what treatment would fail best here, right? And maybe cutting out the baby would be the one that fails the best, because then we'll see if there's ROSC after that, and then we can give thrombolysis once we have like more like really once we have hemostasis, right? So that might be, but now we're arguing from a physiological standpoint, right? We're just arguing and planning out how to do this, right? There's no evidence here. And that's one of the issues here as well. So another example of this kind of what should we do symptomatic wise, like, so this is one of my favorite graphs from when you have an A problem. I have an entire lecture series on just A airway, where I introduced the vortex model. That's one of the models that I think is really important in A. And another really important model in A is this: when do we need to intubate the patient? So on the y-axis we have when we need to intubate, and in increasing urgency. So, or in increasing urgency. So, and on the x-axis we have how likely is it to fail. So, in decreasing order, if you have someone who has a totally obstructed airway, then you have to intubate now, or it favors intubating now, even though the risk is high. It's on this side of the fence, right? So it's really it's probably good to do it now. On the other hand, if you get on this side, then it's not beneficial. You should resuscitate before you intubate. Here you should intubate before you resuscitate. If you have an oxygenation or ventilation problem, well, if the patient is in a really bad way, then no. But otherwise, yes, you should probably intubate here. Airway protection. So someone who is low GCS, well, it depends on why, and there's clear differences between toxicological reasons or someone who doesn't have any reflexes and cannot protect their airway. So there's difference in airway problems from low GCS, right? The GCS under 8 intubate is a trauma thing, not necessarily a medical, like toxicological thing. So depends. And then predicted, like you have your dynamic airway, like you have your blisters after a burn wound, for instance. That's one of the predictors here. That's one of the cases here. And you oftentimes it's not obstructed yet. Here there's no stridor. Then you can usually resuscitate, because what is the risk here? The risk here is you have your anatomical problems. Like if you have someone who has a short neck or has Down syndrome, big tongue, anaphylaxis, and so on. You have your psychological risks, which would be if it's a stressful situation, performance under pressure, and so on. If it's a kid, if it's a pregnant patient, there's a high stakes thing. That's a problem, right? But then you have your physiological ones as well, meaning that if they're hypotensive, if they have asthma, if they have RV failure, if they have low pH, or if they have hypoxemia and you can't get it up with just an IV or any other mean, then you have a huge problem, and then it's a high risk. So the more of these features there are, the longer out here they come. So for instance, in the burn patient, you want to resuscitate. There are burn patient with hypotensive burn patient. They're often out here that you want to treat them first, because they will, during the intubation, they will plummet their blood pressure oftentimes, no matter what kind of drug you use. If they're critically ill, then even ketamine will make them plummet their blood pressure depending on the dose that you're using, right? So use small doses and then try to, if you really have to, but otherwise you need to like resuscitate them first so that they get over here, and then you can intubate them, right? Resuscitation before intubation. So that's kind of the framework for A problems. And we'll go through some of the other mental models and how to fall back on these like systematics. What kind of mental models do I have in my head? And these are not perfect, right? This is a journey for me as well. But I'll try to point out where to go to get better at these. So, and also, and the central model is really this, right? Like you do something, you see if it works, and if it doesn't work, then you have to revise your hypothesis or give more, right? As we talked about. So mental models for C problems. So a really like a med student's mental model might be, oh, it's low blood pressure, give fluids. Yeah. That might be. The next mental model might be that, okay, is it low blood pressure? Okay, it might be hyperperfusion. If it's hyperperfusion, then it's shock, and you have to assess: is it hypovolemic? Is it cardiogenic? Is it obstructive? Is it vasoplegic, or is it distributive? And you can do this with POCUS in a rush exam. And then you could check out high map, right? And then you can see whether this is which one is most likely, and try to treat accordingly. Oftentimes, this is Hictam's dictum. They have more than one to look for. And if you like someone like Sarah Krager has this incredible map of like what she calls the 3 pressures model in someone who's in shock. I'm talking about the forward pressure, map pressure, but also the backwards pressure, and also the colloid pressure, or and talking about that pressure, like fluids going in is only important if it's pressurized. So pressurized fluids gives much more map for your buck than non-pressurized fluids. It's like, yeah. So this is one of the models. If you have a C problem, like you're an anaphylactic patient, and it doesn't help with the thing that you thought it was, like given adrenaline, then I would go back and think about, okay, could it be something else? Systematically go through that, because so you use your system 1, your gestalt is like this. I think it is. These are the data points. I think it might be this. But then you kind of move back and in parallel or afterwards see, okay, gather data with your system 2. Is there anything I'm missing here? All right. For A-B problems, we talked about the vortex model, or you can check that out in my other lectures on A. We have talked about the one of my favorite models that I just showed you on intubations, indication, and resuscitation before intubation. For an A-B problem, you might start off with okay, low saturation, give oxygen. That's true. You might also consider what I often call the dyspnea pyramid, where you have 4 things in the dyspnea pyramid. You have these are the 4 causes of dyspnea. All right, you have lung things, you have heart things, you have blood things, and then you have pH things. And then in this area, you have all the differential diagnoses. We are, of course, most interested in the acute ones. Lung, oftentimes also with lung and airway, I would say. And and I would that's like my model when I came into being a doctor. I used this a lot, but then I learned POCUS, and now it's more like okay, give me an ABG. So I rule out these more rarer ones. And then I'll check out the lungs. Are they wet or are they dry? So is it dyspnea with wet lungs or dry lungs? And as I moved on, there are other mental models that are maybe in parallel with this. Okay, I have NIV. Is it a respiratory failure or is it a hypocapnic failure or is it a mix? Then depending on what kind of NIV NIV settings I'll use, and I'll use either ventilation. If it's a hypocapnic problem, right? I'll be sure to increase the, if you have CPAP minus IPAP, then you'll increase the delta. And if you have just a oxygenation problem, then it's mainly CPAP that is needed, right? And if it's a mix, then I'll do some of both. And your vortex model here, and AMAX4 is also like a good mental model to have. So, and I've done several lectures on this as well. So just to, and Eric Anderson, who was who sadly he died a few years back during COVID, was a Swedish American scientist, psychology or psychologist, I guess, but he was researching in expertise and deliberate. He coined the term deliberate practice, and you can read his book Peak, and I'll talk about it in the non-technical skills part of this. But in general, he would argue that one of the reasons why some people are experts, and what separates one of the things that separate experts from novices is these more advanced and more nuanced mental models, and we have to keep updating our mental models. Like we have to keep etching them to become better and better and better, right? Through case reviews, through talking with our colleagues, how would you do in this situation? Through shadow boxing, all of these things through deliberate practice, right? And we'll talk about that. Their deliberate practice is uncomfortable. Usually, it's hard work, and that's what we, if you want to become experts in this, we have to do. Okay, just some examples of other models that I have in my head. If you have the patient who is hot and altered, like agitated and hot, then you have these differentials, and I know what to do with these. I will I'll try to sedate them at first, and I'll do the O-ABCDE, and I'll check reflexes and clonus and tonus and pupils and skin, and do the axillary handshake in their axilla to see if they're dry or not. And then I have kind of my basis for toxidrome, to see which kind of toxidromes it is. I'll do these blood samples, and then empirically I'll treat them with benzos to sedate them, but also to avoid them ceasing, and also to cool them down, actually, because muscle movement is the main reason for their hypothermia. I'll also actively cool them with towels. I'll get them fluids. I'll consider to do a antibiotic or meningitis treatment, depending on what the context is, and do a blood culture and urine culture, and then aggressive treatment of seizures if they occur. And then I have my syndromes, right? It could be if they're rigid and hyporeflexive or more Parkinsonistic and slowly developed, then it might be malignant hypothermia, rarely, but it more likely would be NMS, malignant neuroleptical syndrome. These need specific treatments, benzos, and so on. So this is an example of like both a generic kind of treatment of this specific syndrome, but also this more advanced specific treatment for specific syndromes once I've gathered all of the data, right? And it might be like the more quickly developed that are more either sweaty or dry, which are anticholinergic syndrome, that are dry as a bat, mad as a hatter, and so on. Dry as a bone, mad as a hatter, blind as a bat. Then these serotonergic syndromes and sympathico-mimetic syndromes, where you need benzodiazepines and active cooling, right? And then you think of the other things like sepsis, meningitis, hypothyroidism, heat stroke, delirium tremens, and salicylate poisoning, and so on. All right, that was the what you do to your patient, right? The ABCDEs, and then we do a sign out after that. And the sign out can be done in different ways. And I don't have a good model for the sign out, but it's mainly like where does the patient has to go, who does it, what do we think this is, and what is the treatment, like what department is it going to. Um, Here is important. It's important to like that before you leave the room, the team must be able to the team must know, okay, what is the plan, right? And what happens like if you're doing transport, then you can use a transport checklist. There are several transport checklists. For instance, if you're going to the CT scan or if you're going somewhere, then you need to know, okay, what are the most likely scenarios that could occur if the patient goes into cardiac arrest? Should we resuscitate? Or have we made a decision to not do that? What if the patient loses their airway? Okay, we don't know what we do then. Is there a high risk of that? Yes, there is. Okay, then we probably should call anesthesia down to help us. Do they want to intubate now, or do we want that's you have to run through the most likely scenarios that could happen. You have to bring the equipment that you need, and you need to have a battle plan if some of these things happen.